And it's time for an ultrasound of the week. I'm Dr. Michael Schick. The patient arrives with lower abdominal pain. On palpation, you think there's a small mass around the inguinal region. The mass looks well circumscribed, and there are a bunch of hyperechoic material anterior in the mass that creates a dirty shadow, which is consistent with air. This is a inguinal hernia. The following clip demonstrates a successful reduction maneuver. We have the same clip, but there is no loop of bowel in it any longer. In regards to hernias, we generally put them in three categories: reducible, incarcerated, or strangulated. Initially, reduction maneuvers should be tried, and if you're able to reduce the hernia, generally those patients can follow up with surgery as an outpatient. However, if you're unable to reduce the hernia, then it could be incarcerated or strangulated. Usually strangulated hernias are very painful. And ultrasound is not thought of as the test of choice. It may not be. You may need to get a CT scan or be using just your physical exam in order to get surgery down quickly. I have used this technique personally and it has changed my management. I've had a couple cases, one very recently, where we thought it was an incarcerated hernia, but with point-of-care ultrasound, it demonstrated another etiology. I recently had a female patient that had a ventral, what seemed like incarcerated hernia, but it was actually a cyst, and we needed just to refer her for biopsy for that. Also, when we're not sure if you have successfully reduced the hernia, you can use this, as demonstrated in this clip, to demonstrate reduction and even assist you in that reduction. Also, you can diagnose a strangulated hernia. So what you're looking for with hernias are the mass with air within it. Worrisome signs are lack of peristalsis within that loop of bowel, the inability to reduce it, of course. And also, you're looking for edema within the bowel wall, so that's a bowel wall thickness of more than 3 millimeters, and adjacent fluid are all signs that this could be an impending emergency. And lastly, you should put some color flow or power Doppler on the loop of bowel and try to demonstrate that there is blood flow to that loop of bowel. In addition to just evaluating the hernia sac, I would go back and look at the rest of the abdomen as well, because what an incarcerated strangulated hernia will do is it'll cause a bowel obstruction. So if you see signs of bowel obstruction with ultrasound, that's just going to add to your exam. There is a very limited amount of literature to support a claim that we can do this with point-of-care ultrasound, but much more is needed in this area. I'm totally stealing some of these references from the ultrasound podcast, but in the International Journal of Surgery back in 2001, they did a study looking at 297 patients, and at least radiologists can diagnose hernias with a 94% sensitivity, so not a bad test. They did another study looking at, within the Surgical Journal of England, and surgeons evaluate patients with suspected hernias, and then they did ultrasound of these patients, and they found that actually the surgeons were pretty sensitive. They were able to diagnose 118 hernias out of 120 patients, but 2 of those patients did not have hernias, and ultrasound was able to diagnose 100% of the patients with hernias, and then diagnose the other 2 patients with other etiologies. So a little bit better than our surgical colleagues' exam, possibly. And then lastly, there was a Scandinavian Journal of Gastroenterology article in 2005, and they looked at 112 patients, and interestingly, when they used ultrasound to target their reduction of hernias, and this was after 2 unsuccessful attempts, that the surgical rate of intervention dropped from 10% to 2%. So this is a small sample size, kind of a retrospective review of those other patients that needed surgical fix, but an interesting study.